In this chapter, we review invasive physiologic monitoring for traumatic brain injury. I'd like to acknowledge the help of my co-author, Guy Rosenthal, in Jerusalem, the section editors, and Dr. Wynn, the editor of Humans, and the editorial staff for making this chapter possible. Why monitoring? Well, in large part, neuroprotection trials have failed in traumatic brain injury, for that matter, and stroke as well. And so much of what we do is geared towards prevention of secondary cerebral insults and secondary brain injury. And this, in large part, is based on our understanding of pathophysiology and how what we do can influence that specific pathophysiology and hence. So in traumatic brain injury, we aim to restore normal physiology as one of the goals in care. And here's a list of physiologic parameters that are recognized to be valuable in the care of patients, not only with traumatic brain injury, but also acute brain injury in general. These physiologic parameters were used in PROTECT, which was one of the more recent phase 3 trials in severe traumatic brain injury that was completed and are codified in ENLS, or Emergency Neurologic Life Support, from the Neurocritical Care Society. And you can see these physiologic parameters include systemic variables such as pulse oximetry, oxygen and carbon dioxide content, and blood pressure, just as they also include intracranial parameters such as intracranial pressure and brain oxygen and cerebral perfusion pressure, and a variety of laboratory-based analyses such as glucose, sodium, INR, and coagulation factors and hemoglobin. To be able to do this requires a monitor. Now, a monitor is derived from the Latin word meaning warn. There are many other meanings attached with the word monitor if one looks it up in the English dictionary. But in medicine, the concept of monitoring is a century or more than a century old, having been adopted into the motto of the American Society of Anesthesiologists in 1905 through the concept of vigilance. What is clear, though, is that clinical observation alone may not always suffice in detecting clinically important factors such as even cyanosis and therefore such deleterious problems such as hypoxia, and hence the concept of physiologic monitors, both invasive and non-invasive, has evolved with time. However, it should be recognized that simply monitoring a patient is not necessarily going to make any difference unless we know what to do with that information. And so we as physicians and healthcare providers, if you wish, need to monitor. In traumatic brain injury, there is great variation in care, and this is data from Center TBI in Europe that looks at several variables in the care of severe traumatic brain injury. Where great variability is seen is in intracranial pressure monitoring, and indeed, perhaps less than half the patients who should have an intracranial pressure monitor do not necessarily have one. So, why do we monitor patients? Well, the goal is to detect a change before it leads to irreversible brain damage. This then allows us to individualize patient care decisions and target our therapy to the patient and their specific pathophysiology. In addition, it allows us to understand the complexity of the patient and monitor the therapeutic response to whatever intervention we use, some of which can have both good and bad effects. In so doing, it is hoped that we can improve neurologic. There are many monitors in use in traumatic brain injury. Central to this is clinical evaluation and serial assessment, and this is often best done with standardized measures such as the Glasgow Coma Scale, the 4-score, or scores such as RAS for agitation, and so forth. Intracranial pressure monitoring is perhaps the most frequently used and is certainly the most well-known form of monitoring, at least invasive monitoring in traumatic brain injury care. And from that, when coupled with systemic measures of blood pressure, allows cerebral perfusion pressure to be calculated. They are non-invasive tools, and included in this is monitoring of electrophysiology such as EEG or SSEPs. Radiology plays an important role in monitoring, although this does provide only a point in time and is not necessarily a continuous monitor. Ideally, we'd like a continuous monitor that's non-invasive with excellent spatial and temporal resolution. But for the most part today, invasive monitoring are the more robust and reliable tools to be used in the intensive care unit. Cerebral blood flow can be measured through transcranial Doppler, laser Doppler, thermal diffusion, and metabolic parameters including brain oxygen and microdialysis add to this cadre of. Intracranial pressure is most frequently monitored and best understood. In large part, it is based on the concept of the Monroe-Kelly doctrine. In essence, within the intracranial vault, there is brain, blood, and CSF. As this changes, whether it be because of cerebral swelling or the evolution of a mass lesion, there is compensation by a decrease in one or more of these three factors, such as blood or CSF. But at some point, decompensation occurs, and in that circumstance, intracranial pressure. The clinical means of detecting this is not always reliable, and hence an intracranial pressure monitor is indicated. The indications have been codified in the Brain Trauma Foundation guidelines published back in 2007. The most recent guidelines do not provide any specific guidance on when an ICP monitor should be inserted. But as a general rule, ICP monitors are indicated in patients with severe traumatic brain injury, i.e. a Glasgow Coma scale of 8 or less, who have an abnormal head CT scan. One may also consider intracranial pressure monitor in a patient with a GCS of 8 or less who has a normal CT scan, but is older than 40, has motor posturing, and a low systolic blood pressure. The Milan Conference in 2014 added further recommendations for more nuanced approaches to ICP monitoring, and certainly this should be considered in those with contusions, particularly when clinical examination is unreliable, and even following a secondary decompressive craniectomy, which has been performed for raised intracranial pressure. One may consider an ICP monitor in patients who also have insults such as prolonged hypoxia or hypotension, when CT findings suggest raised intracranial pressure, and specifically effacement or compression of the perimesencephalic cisterns. And in those patients who've undergone surgery, these variables play an important role in decisions about the use of intracranial pressure. Does this make a difference? Or how can it be, or which ICP monitors can be used? There are many, but for the most part it's recommended that either a parenchymal ICP monitor or external ventricular drain be used, the choice of which may depend on the patient, i.e. has somebody got hydrocephalus or not. In studies that have compared outcome, it seems as though patients with parenchymal ICP monitors actually do better than those who have ventricular catheters. Less the choice may depend on the patient-specific anatomy and pathophysiology. Does it make a difference to outcome? It does, and specifically mortality, There's no question that the higher the ICP and the more refractory it is to treatment, the worse the outcome. This is true of mortality. It is not clear that this actually affects favorable or unfavorable morbidity. Well, does monitoring make a difference? Several years ago, the BEST TRIPS trial was published in the New England Journal of Medicine based on a trial conducted in South America with NIH funding. In this trial, patients older than 13 years of age with severe traumatic brain injury were managed with two strategies of care, one of which was triggered by an intracranial pressure monitor and the other by clinical evaluation and CT findings, i.e. both groups of patients received the similar cases of intracranial pressure. Not surprisingly, the outcome was the same. And this created immense debate in the literature and the academic field of traumatic brain injury management. And to the credit of the investigators, they brought together a group of experts to try and put perspective on this. What BEST TRIPS trial did was a trial that tested the efficacy of two treatment protocols for patients with severe head injury. It was not a trial on intracranial pressure monitoring. It was not a trial on the efficacy of intracranial pressure monitoring, nor was it a trial of whether treatment of intracranial pressure makes a difference, because many of these patients never had high ICP. Secondly, the trial had very low external variability, which makes it difficult to generalize to severe traumatic brain injury as a whole. However, it was a well-performed study with high internal validity, and it's recognized that it shouldn't change clinical practice, but its primary impact was research-oriented. Interestingly, one of the questions that was perhaps most important, as recognized by the consensus group, was what defines intracranial hypertension. Many other studies, in large part, derived from administrative databases or based on clinical observation where intracranial pressure monitoring or guideline adherence is examined, does demonstrate a value to using an intracranial pressure monitor with lower mortality in those patients who have an ICP monitor and guideline adherence is. Most recently, the Seattle International Severe Traumatic Brain Injury Consensus Conference, or CBIC, has helped codify management using this tiered approach. This tiered approach is in large part derived from BOOST 2, a recent phase 2 trial that looked at multimodality monitoring. And this is a useful algorithm, if you wish, on how to manage ICP. The importance of this is that a variety of treatment options are available in each tier. The principles in using a tier is that not every treatment has to be used, but if ICP is not controlled, one escalates care. Included in this is the value of a mean arterial pressure challenge to look at autoregulation to hence guide care. It is well recognized that intracranial pressure is perhaps the tip of the iceberg. When using an ICP monitor coupled with blood pressure, we have a sense of perfusion pressure. This may be what could be labeled, if it decreases, is classical ischemia. However, within the brain, many other pathophysiologic mechanisms of brain injury occur, including microvascular ischemia, which is a diffusion abnormality, and mitochondrial dysfunction. These two will not be identified by using an perfusion pressure monitoring. In addition, studies of metabolism demonstrate that biochemical changes, metabolic changes, and evidence for cell energy dysfunction often occur before the rise in intracranial. Hence, there is a movement away from looking simply at ICP as a number or a threshold. Instead, it is to be regarded as an indicator of some underlying pathophysiologic process that requires treatment. In so doing, becomes feasible. There are many factors that may influence intracranial pressure, including compliance, herniation tendency, ischemia, hypoxia, or cellular dysfunction within the brain. And hence the important question is not necessarily what to do if the intracranial pressure is increased, but why is it increased? Because that then leads to more treatment. So this evolves into the concept of multimodality monitoring. And here, monitoring is used to understand how the brain is at risk and is led to the concept of permissive intracranial hypertension, where in some circumstances, mild elevation in intracranial pressure may be tolerated when other parameters of brain health are normal. And this is important because ICP management, while good, also has some deleterious side effects. Here is a list of some of those features, looking at perfusion pressure, neurologic function through EEG, blood flow through TCD or thermal diffusion probes, looking at the flow and metabolism, brain oxygen, microdialysis, and pressure order regulation. Compliance is important, and compliance indicates the ability of the brain to compensate for the development of a mass lesion or swelling. This could be simply identified by looking at waveforms, and the second wave of the ICP wave is elevated when there's poor compliance. There are the tools that allow this to be evaluated too, and derived indices have developed, such as PRX. PRX looks at the moving coefficient between mean arterial blood pressure and intracranial pressure. And when used, it provides individualized ICP thresholds. Those often appear to be more robust in the prediction of outcome versus population-based. In addition, these derived parameters, such as PRX or RAP, can help decide whether treatment should be based on ICP control or CPP, cerebral perfusion pressure therapy. And a shift in this slope determines whether one uses ICP-based care, in the dotted line, or perfusion pressure-based. In particular, the estimation of an optimal cerebral perfusion pressure can be estimated using PRX, i.e. a derived index of ICP. There's been great variation as to what cerebral perfusion pressure is optimal, and current guidelines suggest between 60 and 70. Earlier guidelines had suggested greater than 70. But it is clear that CPP-based therapy can, in some circumstances, not necessarily improve outcome in aggregate, because trying to augment perfusion pressure can lead to lung problems. And so calculating the optimal perfusion pressure for an individual is ideal. And in patients who maintain perfusion pressure in their optimal range, do better. Not surprisingly, is a U-shaped curve, as is seen in much of. There is evidence that even when perfusion pressure and intracranial pressure is normal, cellular dysfunction may occur in the brain. This is a very elegant PET study that demonstrated PET markers of cellular hypoxia in the face of normal perfusion pressure. And other studies have shown this is related to a diffusion abnormality of oxygen rather than a perfusion abnormality, i.e., using an ICP monitor and estimating cerebral perfusion pressure would not detect this. Hence, efforts have been made to measure oxygen in the brain. This can be achieved via a variety of monitors. Perhaps the gold standard is PET, but that is not necessarily feasible in most intensive care units. Jugular venous saturation of oxygen, or calculation of the arteriovenous difference of oxygen using a jugular catheter. But perhaps more frequently used are parenchymal brain oxygen monitors. There are several on the market. The one that has been studied most is the Lycox, based on the Clark electrode. And this is a simple parenchymal monitor that can be inserted with an ICP monitor through a triple lumen catheter, and normal brain oxygen is defined as greater than 25 to 30 millimeters of mercury, and treatment should be initiated somewhere between 15 and 20 millimeters of mercury or less. The brain oxygen monitor, however, is not a blood flow monitor. Instead, in this elegant study, which used oxygen, arterial blood pressure, and hyperventilation challenges, what defined brain oxygen was the product of blood flow and the arteriovenous tension of oxygen. An important question on brain oxygen monitors is where to insert them. This, too, applies with parenchymal ICP monitors or any parenchymal monitor. And there are two basic schools of thought. Place it in pericontusional tissue or close to an abnormality, or place it in normal tissue. If placed in normal tissue, the study that looked at xenon CT-based blood flow studies showed that the value of oxygen in this quadrant was the same as any other quadrant in the brain, provided the device was in. Having said that, it is important to recognize that probe position is important. And hence, a CT scan after insertion of an ICP monitor or brain oxygen monitor or microdialysis catheter is valuable because it then allows correct interpretation of the data. Does brain oxygen make a difference to outcome? The short answer is yes. And perhaps importantly, and different from intracranial pressure, this relationship is seen not only in mortality, but also in favorable or unfavorable outcome. Importantly, this is an independent variable. And in this study that looked at patients with severe traumatic brain injury, parameters such as the Marshall CT score, i.e. an anatomic variable, the Apache score that looked at the overall physiology of the patient, brain oxygen, and ICP were looked at and evaluated for the impact on outcome. The burden of brain tissue hypoxia remained an independent variable associated with adverse outcome, unlike intracranial hypoxia. Microdialysis takes us a step further, looking at metabolism. This can be achieved by a bedside analytic device. It still remains reasonably labor-intensive, but as the tools have advanced, it's becoming more frequently used in practice. In essence, what microdialysis does is infuse a fluid and then analyzes metabolites in the extracellular. Perhaps the most frequently evaluated are glucose, pyruvate, and lactate. In addition, glycerol, a marker of cell degradation, can be monitored, as can excitatory amino acids such as glutamate. Calculation of the lactate-pyruvate ratio helps determine, based on what pyruvate is doing, whether there's ischemic hypoglycolysis or non-ischemic changes to cellular function. And as you can see, the reasons for these are different, and hence treatment can be further targeted to specific pathophysiology in individuals. Control of blood glucose is known to be important in brain injury, but extreme tight control of blood glucose can have a significant deleterious effect on brain glucose. What's become apparent is that lower levels of brain glucose are associated with worse outcome in brain injury, and hence it has been suggested that microdialysis may more appropriately guide glucose control in patients with acute brain injury, including severe traumatic. As with brain oxygen or parenchymal ICP probes, where the device is inserted may be important. Here you can see one next to the subdural hematoma where the lactate pyruvate ratio is higher compared to one distant to that subdural hematoma. And that lactate pyruvate ratio helps define whether there's cellular dysfunction or not. The increase in this patient is associated with low cerebral perfusion pressure, and once the blood pressure is increased to augment perfusion pressure, you then see a decline in lactate. Measuring blood flow is important. This can be done through imaging techniques. It can be done non-invasively with transcranial Doppler, which provides a surrogate of blood flow, or invasive monitors such as laser Doppler or thermal diffusion. There are these technologies, and all have pros and cons, and some provide qualitative information versus quantitative information. Thermal diffusion has been well studied and is recognized that blood flow is influenced by many factors: blood pressure, intracranial pressure, venous outflow, viscosity, oxygen and CO2 levels, vasoactivity, autoregulation, and the threshold for ischemia is less than 18 to 20 mils per 100 grams a minute. Blood flow when less than 25 leads to a change in EEG. Consciousness is usually lost at less than 20 mils per 100 grams a minute, and irreversible brain damage occurs when the blood flow is less than 10 millimeters per 100 grams. As I mentioned, a variety of tools are available. This is one such example, measurement of thermal diffusion, where you can see the decrease on the probe correlates with a shift on perfusion CT. Similarly, one can use a blood flow monitor to look at other variables. For example, hyperventilation is known to decrease intracranial pressure, but if used inappropriately through vasoconstriction can lead to ischemia. On the other hand, understanding what CO2 challenges do to blood flow can allow one to optimize hyperventilation or ventilation parameters in a patient with severe traumatic brain. In short, monitoring in severe traumatic brain injury requires a multimodal approach. This can be defined as the simultaneous collection of data from multiple diverse sources. And these are complementary because no one single method can provide complete. We often see multimodality monitoring as a variety of probes put in the brain. Here's a ICP monitor, brain oxygen probe, and microdose. But in essence, multimodality monitoring should be regarded as the clinical evaluation, use of CT, use of a monitor, for example, an ICP monitor, EEG, brain oxygen, and also laboratory analysis. There's no one single monitor that's superior to any other. Instead, the various monitors have to be looked at as complementary and supplementary. What is clear, though, is that multimodality monitoring does make a difference to outcome. And in this study, looking at levels of care defined in large part by multimodality monitoring, that made a significant difference to outcome at each decile of age, including in 80-year-olds. Cost effectiveness similarly was improved in this circumstance, except in the 80-year-olds, perhaps because of their shortened life expectancy. The concept of multimodality monitoring and its impact on outcome has been evaluated in a randomized trial. This was BOOST 2, the brain oxygen outcome study in severe traumatic brain injury. This was a phase 2 trial. It was primarily designed to evaluate physiologic efficacy, which was demonstrated. It was not powered to look at outcome, but there was an improvement in outcome in those patients who underwent multimodality monitoring. This led to BOOST 3, a large phase 3 trial that is now underway to further evaluate the concept. It should be recognized that it still remains difficult to show that any single monitor has a positive impact on outcome, because the outcome is not determined by the monitor, but rather by the treatment and how one responds to the physiology or the physiologic derangement that occurs. to integrate that information. And we need information to help understand this pathology. Integrating multi-monitors is feasible. There are many challenges, some of which are related to the devices and their interfaces, time synchronization, regulatory issues, but it can be done. And in information, one gets a better picture of what's happening. There are challenges in the future, in particular data accuracy, which in large part revolves around artifact rejection. Data integration, how to display this, coupled with decision support. Is this going to be cost effective, particularly in the real? It is important to recognize, as I hope has already been mentioned in this talk, is that the information from a monitor alone is not sufficient. What is important is how one responds to that and having a therapeutic option. Several years ago, the Neurocritical Care Society, the European Society of Intensive Care Medicine, and the Society for Critical Care Medicine had a large consensus conference on multimodality monitoring. This provides us for the future, and several guidelines have evolved since then in a variety of tools such as intracranial pressure, microdialysis, and so on. And this provides the basis for our care moving ahead. So the key points. Traumatic brain injury in large part depends on the prevention, identification, and management of secondary brain insults. This requires monitoring. There are many techniques that are available, including the clinical evaluation, imaging, and physiologic parameters. These physiologic parameters could be monitored with non-invasive or invasive techniques, but they should be integrated together to provide targeted and individualized care. The cornerstone of neuromonitoring remains intracranial pressure monitoring, and there's a clear relationship between increased intracranial pressure and mortality. What is now apparent is intracranial pressure is not simply a single numeric value or threshold, but looking at total ICP dose, the temporal evolution of intracranial pressure, how it responds to treatment, individual thresholds based on derived indices such as PRX may be far more important than simply looking at a numeric threshold. Using multimodality monitoring, coupled with intracranial pressure monitoring, this includes brain oxygen, blood flow, or metabolism, will augment and supplement ICP monitoring, and early studies suggest that this can help enhance outcome. Thank you very much.